So the next drug that we talked about was suvorexant for treatment of insomnia. So this is a drug that works through a novel mechanism blocking receptors in the brain that are involved with sleep and wakefulness. So it works by a different mechanism than existing therapy. And it has been FDA approved for the treatment of insomnia based on some trials that we looked at this morning. Insomnia is defined variably. There's research definitions so that when patients enroll in trials, we know that they're all comparable to each other. In practice, and reviewing this from my talk, for example, I learned that up to 30 to 50% of US adults have some problem with insomnia, and as many as 10 or 20% meet the definition for chronic insomnia that's used in these types of trials. So it's a very common problem, and clearly if we had another treatment alternative that was better than the existing therapy, there would be a big role for that. So we looked at the evidence for two primary outcomes. One would be total sleep time, how it compares with placebo or in indirect comparisons with current therapies, and then also the time to sleep onset, how long does it take after they hit the pillow before they go to bed. We found that the evidence for this was comparable to existing therapies in terms of its effect on both of those. It's actually quite remarkable if you look at the literature. None of these drugs make a huge difference in sleep. The types of differences that are considered to be favorable and allowed to be approved would be, for example, falling asleep about 10 minutes more quickly and total sleep time of about 30 to 40 minutes more over the whole course of the night. And that's where this drug fit in as well. So these are small differences that may still be meaningful for our patients, but that's the kind of effect that you see with hypnotics. They are very small differences. I think if we actually presented that to patients, they might, in some cases, choose to try other strategies besides medication. So what we sometimes called the Z drugs, which work through the benzodiazepine receptor, but not actually benzodiazepines, the prototype of which would be zolpidem. And there have been issues with those drugs of so-called complex sleep-related behaviors, and that can be sleepwalking, for example. People even can undertake other activities in the middle of the night and have no recollection of them, and have amnesia for the event the next morning. Those types of complex behaviors weren't described in the trials of the new drug of suvorexant, although a relatively small number of patients were studied. But what the FDA was concerned about in particular with this new drug was more about impaired cognitive performance the next day. That is, what we might call the morning hangover, which they were more concerned about than the complex sleep-related behaviors that have been seen with the Z drugs. Well, in the trials, there was not too much of a problem with impaired cognitive function the next morning. They did ask the manufacturer to submit a study on a smaller number of patients in unpublished data, where they looked at the effect on driving the next day, and they found at the higher doses that had been used in some of the clinical trials that many patients had impaired driving performance the following day. And this was particularly the case in the elderly patients. So when the FDA approved this, they recommended two things. One is that the dose would be lower than the maximum dose used in the trials. And the second one is that patients shouldn't take this unless they have at least 7 hours when they take the pill and when they expect to wake up, to minimize that effect of a residual drug effect in the morning and impaired performance. So I would suggest, because of that issue about impaired performance the next day, and the concern in the elderly, and it's quite expensive. It's much more expensive by more than an order of magnitude than the generic Z drugs or benzodiazepines. That really should never be a first-line option because the overall safety profile was not too different than existing therapy, and the efficacy that we talked about was similar. I think it can be used as a third-line option in patients who do require drug therapy for insomnia, who have been through one or more likely several of the existing drugs that were ineffective or had side effects. And it may have a role there, but it should not be used first line because primarily of the cost concern.